Welcome back to the deep dive. I was thinking about this on the way in today. We have this tendency to trivialize ear infections.
We really do.
You think of a toddler, tugging at their ear, maybe some pink medicine, a couple of tears, and then it's over.
It's almost a rite of passage. For the vast majority of people, it's like a tummy ache of the head, just a temporary annoyance that goes away.
Exactly. But today, we are looking at something much darker. We're moving past that acute childhood version and looking at the chronic, destructive kind.
The kind that doesn't just go away.
No. The kind that requires some serious medical detective work to unravel. We are diving into chronic suppurative otitis media, or CSOM.
And it is a fascinating topic because it forces us to look at the ear not just as this, isolated organ, but as a really complex mechanical system that can go wrong in very specific and sometimes very dangerous ways.
To guide us through this, we aren't just summarizing a textbook. We have a really cool source today. We are analyzing a transcript of a detailed clinical case presentation.
Which is fantastic.
It's a medical student, Mr. Kunj, presenting a live case to his expert mentors, Dr. Puneeth and Dr. Shraddha, at a teaching hospital.
And that's a great kind of source because it gives us the raw step-by-step logic that doctors actually use. In a textbook, the answer is just right there at the top of the page.
Right.
Here we see the symptoms first, and you have to earn the diagnosis. It's not, here is the disease, it's, here's the clue, and here's what we do next.
It's literally like an episode of House, but hopefully with a much better bedside manner.
We can hope.
So our mission today is to decode the jargon. We want to walk you, the listener, through exactly how a doctor diagnoses ear disease, from that very first question they ask to the final surgical plan.
And we're going to highlight the why behind every single step, because as we'll see, even a seemingly random question can have a massive implication for the diagnosis.
Okay, let's unpack this. Let's meet our patient. In the presentation, the student, Mr. Kunj, introduces a primary case subject. Who are we dealing with?
So the primary focus of his clinical exam is a 20-year-old female. Now, the source material does briefly mention a 68-year-old case at the beginning, sort of to illustrate a point. But the deep dive of the clinical findings, the real meat of the diagnosis, is focused on this 20-year-old woman.
Got it. So a young woman, 20 years old, she walks into the clinic. What's bothering her? What are the chief complaints?
She has two main issues. First, she has discharge coming from her left ear. In medical terms, we call this otorrhea.
Otorrhea, okay.
And second, she's noticed a pretty significant decrease in hearing in that same ear.
Discharge and hearing loss. Not a great combination. But I noticed the medical student didn't just say her ear is leaking. He got really specific.
Right. And this is where the detective work starts. He notes that the discharge started 2 months ago. Initially, it was intermittent.
Meaning it came and went.
Exactly. And it was yellowish. But, and here's the crucial shift, in the last 5 days before she came in, it became continuous.
And the texture changed too, didn't it?
It did. It became thick and purulent.
Purulent. I always see that word in these medical papers. Is that just a polite way of saying pus?
Unfortunately, yes. It implies an active infection. It means your immune system is at war with bacteria in there, and the casualty of that war is pus.
Okay, I want to pause on the gunk for a second.
Yeah.
I know it's gross, but the source material really hammered home the importance of describing it. Why do doctors obsess over whether it's yellow or thick or slimy?
It matters immensely.
Does it really change the treatment?
It's one of the biggest clues we have to categorize the danger level. You see, the nature of the discharge tells us what part of the ear is angry, and more importantly, whether the bone is rotting.
Whoa, hold on. Bone rotting.
Yes. Generally, we look for two main types of discharge. You have mucoid discharge. This is thick, usually sticky, like mucus. It comes from the mucus glands, which tells us the problem is likely in the anterior part of the middle ear or the eustachian tube.
Okay, so that's the slime.
Right. Then you have purulent, which is what our patient has now. That means active bacterial infection. But the most critical question the mentors asked was about the smell.
The source mentioned it was non-foul smelling. I just assumed that was a hygiene thing. Like, good for you, it doesn't stink.
It is so much more than hygiene. It is a diagnostic fork in the road. If the discharge smells foul, and I mean room-clearing, rotting cheese bad, it usually indicates a condition called cholesteatoma.
Cholesteatoma, that sounds like a dinosaur.
It might as well be. It's a destructive skin cyst. It grows into the middle ear and releases these enzymes that literally eat away the bone.
You're kidding.
No, it can erode the hearing bones, the mastoid bone, and even the bone separating the ear from the brain. We call that unsafe CSM.
That is terrifying. So a bad smell basically equals bone destruction.
Often, yes. It indicates osteitis, inflammation of the bone. But in our patient's case, the discharge is thick and purulent, but non-foul smelling.
Which points us toward?
It points us toward the safe type. We call it tubotympanic disease. It means the infection is limited to the mucosa, the lining of the ear. It's messy, it's active, there is pus, but it is likely not eating a hole through her skull base.
Well, that's a relief. Your ear is leaking pus, but at least your skull is intact.
In the ENT world, that is a victory.
So the student identifies this as the safe but active type. Then he starts asking questions about triggers. He asks if she's had a cold recently. An upper respiratory tract infection.
This is to rule out the source. If you have a cold, the infection can travel up the eustachian tube, that little tube connecting the back of your nose to your ear, and cause acute otitis media.
But she said no.
Our patient denied any recent colds, so if the enemy didn't come from the inside, it must have come from the outside. He likely asked about water getting in the ear.
Like from swimming.
Or even just bathing. Imagine you have a hole in your eardrum, a perforation. If you stand under a shower and let tap water run directly into your ear, you are washing bacteria from your skin and your hair right into that sterile middle ear space.
It's like leaving the front door open during a hurricane.
Perfect analogy. It turns a dormant, dry ear into an active, leaking one. And the student notes she had a flare-up recently, which aligns perfectly with that.
Okay, so we have a 20-year-old with a sudden flare-up. Now, let's move to the history taking. The source puts a huge emphasis on digging into the patient's past. And frankly, some of it seemed completely unrelated to ears.
Like what?
Like diabetes. The mentors were absolutely grilling the student about checking for diabetes mellitus. Why? She's 20, she's there for an earache, not a foot ulcer. Why are we checking her blood sugar?
This connects to the bigger picture. You cannot treat the ear in isolation. If a patient has uncontrolled diabetes, two things happen. First, bacteria love sugar. High blood sugar is like a buffet for infection.
Right.
Second, diabetes cripples the immune system's ability to fight back, and it slows down wound healing.
So the infection would be harder to kill.
Much harder. And worse, diabetics are prone to a specific nasty complication called malignant otitis externa. It's where the infection spreads from the ear canal into the skull base bones. It causes severe, excruciating pain and acts almost like a cancer in how it invades tissue.
Yikes, so checking sugar isn't just a formality.
No, it changes the entire surgical game plan. You cannot operate on an ear if the sugar is uncontrolled because the wound simply won't heal. The graft, that patch you put on the eardrum will just rot away.
That makes perfect sense. The source also flags some lifestyle factors. The patient, again, she's only 20, had a history of smoking and alcohol.
Which is significant. We We often think of smoking as a lung issue, but it destroys the ear too. Your middle ear and eustachian tube are lined with cilia,
Cilia,
tiny microscopic hairs that beat in a rhythm to sweep away mucus and debris.
like a built-in broom system.
Exactly. Smoking paralyzes those cilia, so the ear loses its self-cleaning mechanism, the gunk builds up, bacteria colonize it, and you get chronic infections. Plus, smoking constricts blood vessels. If we want to rebuild her eardrum surgically, we need good blood flow.
And a smoker's ear just doesn't have that.
It's a very difficult environment to heal.
And then there was this detail that made my eyebrows go up. She had lost 10 kilograms in 2 months. That's like 22 pounds.
Right, and she wasn't trying to lose it.
That is a massive red flag, isn't it?
Huge. In medicine, significant unintentional weight loss always screams systemic disease. My mind immediately goes to malignancy cancer or a chronic infection like tuberculosis.
TB. In the ear.
It's rare, but yes, tuberculosis otitis media is a real thing. It usually presents with multiple perforations in the drum and pale granulation tissue.
Or it could just be a sign her whole system is weak.
Exactly. The weight loss could mean she has pulmonary TB, and her body is so consumed by fighting that infection that she's wasting away, and the ear is just a side effect of a collapsed immune system.
It really is detective work. Now, there was one more warning in the history section that I found really scary. Ototoxicity.
This is a critical point for anyone listening. The source discusses the danger of previous treatments, specifically the use of eardrops or antibiotics that contain aminoglycosides.
Aminoglycosides. That's a mouthful. What are those?
They are a class of powerful antibiotics drugs like gentamicin or neomycin. They're excellent at killing bacteria, but they have a terrible side effect. They are toxic to the hair cells in the cochlea.
They're inner ear cells that actually detect sound.
Correct. And unlike your skin, those hair cells do not grow back. If a patient has a perforation, a hole in the drum, and they indiscriminately pour these drops into their ear, the liquid can seep through the hole, cross into the inner ear, and poison those nerves.
So in trying to cure the infection, you could accidentally deafen the patient.
Precisely. You fix the wet ear, but you leave them with permanent sensorineural hearing loss. That's why the mentors emphasized asking about previous treatment.
Because the hearing loss might not be from the infection.
It might be iatrogenic.
Iatrogenic.
Doctor caused. Or, well, treatment caused.
That is a sobering thought. Check your labels, people. Okay, so we've grilled the patient, we've checked her sugar, we've warned her about the drops. Now it's time to actually look at the patient. Part 3, the examination.
And again, we start broad. The head-to-toe check, the general physical examination.
Checking for pallor, cyanosis, clubbing.
Exactly. Clubbing of the fingers, where the fingertips get bulbous, can indicate chronic lung or heart disease. Pallor suggests anemia. Anemia means poor oxygen delivery to tissues, which means, you guessed it,
Poor wound healing. It all comes back to healing.
always. Okay, so let's zoom in. The doctor finally touches the ear. What are they looking for on the outside?
They're inspecting the pin of the outer ear flap and the mastoid area, right? That hard bone behind your ear.
Yes, palpation. They are checking for mastoid tenderness. If you press on that bone and the patient winces, it suggests mastoiditis. That means the infection has spread from the middle ear airspace into the honeycomb of bone behind it.
Which is bad.
That is a surgical emergency because it's a hop, skip, and a jump to the brain from there.
But in this case,
No tenderness was mentioned, which is good. So they move to otoscopy. They take a little light and look inside.
and here's the reveal. What did they see?
They saw the culprit, a central perforation in the tympanic membrane.
A hole in the eardrum. The student got really specific here. He said it was in the anteroposterior quadrant and measured roughly 4 by 4 millimeters.
Right.
It's 4 millimeters big. It sounds small.
In the world of eardrums, it's significant. The entire eardrum is only about 10 millimeters in diameter, so a 4 millimeter hole covers about 30 to 40% of the surface area. The source classifies this as a moderate perforation.
Wow, so almost half her eardrum is effectively open.
A good chunk of it, yes. And through that hole, they could see the middle ear lining was red and congested with that purulent discharge we talked about.
But the key here was the location, right? Why did they call it a central perforation?
Central means the hole is surrounded by a rim of remaining eardrum. It's not touching the bone at the edges. This is crucial because a central perforation is almost always the safe type.
And if it wasn't central?
If the hole goes all the way to the edge, what we call a marginal perforation, that's where the skin from the ear canal can grow into the middle ear and form that dangerous cholestotoma.
I see. So the rim acts like a barrier.
Exactly. Her rim was intact, confirming the diagnosis of safe tubotympanic C-SALT.
So we have a hole, we have pus, we know why it's leaking. But what about the hearing? This brings us to part 4, the tuning forks.
I love this part. In an age of MRI and high-tech scans, the humble tuning fork is still the bedrock of diagnosis. It's pure physics.
It feels very 19th century. You literally whack a metal fork and hold it next to someone's head.
And it works. They use 2 main tests, the Rin test and the Weber test. And frankly, these are often misunderstood, so let's break them down.
Please do. Let's start with the Rin test.
So you strike the fork, you place the base on the mastoid bone behind the ear. That tests bone conduction. The vibration travels through the skull directly to the cochlea, bypassing the eardrum.
Okay, so that checks if the nerve is working.
Right. Then you move the vibrating prongs next to the ear canal. That tests air conduction sound going through the air, vibrating the drum, moving the bones, and then hitting the cochlea.
And normally air conduction should be better, right? Because the eardrum acts like an amplifier.
Exactly. A healthy ear hears it louder through the air. That's a positive Rin. But in our patient, the Rin was negative in the left ear.
Meaning she heard it louder through the bone.
Correct. That tells us the nerve is fine because the bone conducted it, but the mechanism, the eardrum and bones, is broken. The sound isn't getting in the front door. We call this conductive hearing loss.
Okay, that makes sense. Now the Weber test. This is the one that always confuses me.
The Weber is brilliant. You place the vibrating fork right in the middle of the forehead, and you ask, where do you hear the sound?
And logically, if I have a bad left ear, I should hear the sound of my right ear, the good one.
That's what intuition says, but physics says otherwise. In conductive hearing loss, the sound actually lateralizes. It moves to the bad ear.
Wait, why? That seems completely backward. Why would I hear it louder in the ear that's broken?
Think about it this way. Have you ever plugged your ears with your fingers and hummed?
That's true.
Try now. Just plug one ear tightly and hum.
Okay. Oh, it's way louder in the plugged ear.
Exactly. That's called the occlusion effect. When you have a conductive loss, like a hole or fluid or wax, you are blocking the ambient noise of the room. That masking noise is gone. So the bone vibration coming from inside your head has no competition. It resonates in that closed chamber.
So because the Weber lateralized to her left, her bad ear, it confirmed that her nerve is alive, that the ear is blocked.
Precisely. If she had nerve damage, the sound would have gone to the good ear, but it went to the bad ear, confirming conductive hearing loss.
That is so cool. It's like a magic trick that diagnoses a disease. So we have CSM, we have a moderate hole, we have conductive hearing loss. Now, how do we fix it? Part 5, management.
The host asks, can we just operate? And the answer is, not
No.
so fast.
Right, we need a plan
We need pre-op investigations. First, we need a culture and sensitivity test. We take a swab of that pus and send it to the lab,
to see what bugs are growing.
and more importantly, what kills them. You don't want to start antibiotics blindly. You want to use a sniper rifle, not a shotgun. We need to dry up this ear before we operate.
Operating on a wet ear is a bad idea.
It's a recipe for graft failure. Then there was something about microscopy.
Yes.
The doctor needs to look under a microscope to check for hidden enemies. Sometimes behind the pus there are polyps or granulation tissue or tiny pockets of that dangerous cholesteatoma we mentioned. You can't see those with just a flashlight.
And finally, audiometry.
That's the fancy hearing test in the soundproof booth. The tuning forks give us a yes-no answer, but audiometry gives us a graph. It maps the earbone gap. It tells us exactly how many decibels of hearing she has lost.
Okay, once the ear is dry and mapped, what is the surgical solution? The Force mentioned laryngoplasty and tympanoplasty. They sound almost identical.
They are cousins, but with different scopes of work. Think of it like home repair. Laryngoplasty is like patching a hole in the drywall. You are just repairing the eardrum.
Just closing the window.
Right. But tympanoplasty is a broader term. It involves patching the drywall and fixing the electrical wiring behind it.
The wiring being the bones.
The acicula chain, the malleus, and claudicus, and stapes. In chronic infections, these tiny bones often get eroded or disconnected. If you just patch the drum but leave the bones broken, the sound still won't get to the nerve.
So the patient would have a dry ear,
Yep.
but they still wouldn't be able to hear.
Exactly. So the goal is twofold. Goal 1, a dry ear. Stop the discharge, close the hole, prevent dangerous spread. Goal 2, restore function. Reconnect the ossicle so she can hear again.
It really is a reconstruction project. You're rebuilding the mechanics of a sensory organ.
It is delicate, precise work. Millimeters matter.
So what does this all mean? We started with a leaky ear and ended up with a lesson in mechanics, microbiology, and even lifestyle choices.
If we connect this to the bigger picture, it really highlights that the ear is not an island. You can't just look at the hole in the drum.
Right. Diabetes matters. Smoking matters. The antibiotic drops she took 3 years ago matter.
Exactly. The source material really drives home that managing CSOM isn't just about surgery, it's about managing the whole patient. If you miss the diabetes, the surgery fails. If you miss the cholesteatoma, the patient is in real danger.
And I think that's a huge takeaway for our listeners. Being a good patient or a good advocate for yourself means understanding that your entire history tells a story.
Absolutely.
Before we wrap up, I want to leave everyone with one final thought from the source material that really stuck with me.
What's that?
The Force mentioned checking for a decline in taste sensation.
Ah, yes. The chorda tympani.
It seems so random. The doctor asked, "Can you taste your dinner?" But it turns out there's a reason.
It's a quirk of our anatomy. The nerve that carries taste sensation from the front 2/3 of your tongue, called the chorda tympani, takes a very strange shortcut. It runs right through the middle ear space.
It literally just hangs there.
Like a clothesline across the room. It passes right between the malleus and the incus bones.
So if the middle ear is full of infection,
That nerve is bathing in pus and inflammation. It can get damaged. So a simple decline in how your food tastes, specifically a metallic taste or loss of flavor on one side of your tongue, could be a subtle clue that the ear disease is aggressive and affecting the structures inside.
it just goes to show the body gives us clues in the strangest ways. We just have to know how to listen to them.
Or in this case, taste them.
Exactly. That's all for today's deep dive into the fascinating, slightly gross, but incredibly logical world of CSUM. Thanks for listening.
Stay curious.